Welcome to AETCM, the emergency medicine channel. Shall I start?
Yes.
A 50-year-old male patient with no known comorbidities presented to the ER with complaints of fever, myalgia, lower back pain for the past 1 week with reduced urine output for 1 day. Initially, he went to a local hospital and found to have hypotension 90/60 mm of Hg of BP and tachycardia 120 per minute and hypoglycemia 46. And from there, they started on IV fluids and also inotropic support is also started from outside hospital, noradrenaline 2 ml per hour and referred here for
What is your
further
opinion
management.
about this hypoglycemia? Is he diabetic?
Not non-case of
So tell me the reasons for spontaneous hypoglycemia.
maybe any liver dysfunction.
Means severe liver dysfunction.
Maybe nutritional deficiency.
Hypoglycemia. If you don't take anything today, you will not go to hypoglycemia. That means you will have alternative metabolic pathways. So what are the other reasons? Okay, if there is no other things, insulinoma, adrenaline insufficiency can be there in the sepsis and all. Severe infection including malaria, sepsis including malaria. So these are the common causes. So here what may be the reason?
In this case, patient is in sepsis. So
sepsis itself can be liver damage. Okay.
And referred here for further management. On arrival, initial 10-second assessment, patient
hypotension, hypoglycemia. So what else? Severe liver disease. You told liver disease, sepsis. Third one. We already told.
Adrenaline insufficiency.
So that we have to be very careful.
And on initial 10-second assessment, patient is conscious oriented, airways patent, no pooling of secretions. Coming to breathing, respiratory rate is 28 per minute with a saturation of 87% in room air. And on chest auscultation, right-sided lower zone crepitations are there. So at that time, we give oxygen support to the patient with a face mask of 6 liter O2. And coming to circulation, BP is 90/60 with pulse rate of 148. And peripheries are cold with CRT more than 3 seconds. And at that point, we done one. Already the patient is on IV fluids maintenance from that hospital. They discontinued the noradrenaline support from there itself. So on arrival, the BP is only 90/60. And on doing the POCUS, IVC is collapsing, global LV hypokinesia and moderate LV dysfunction is there. So we continued the fluids and maintenance only, and we started on the inotropic support initially. And disability wise,
why you are not given fluid?
Already it was given from the outside.
How much was given? But your ultrasound shows
IVC is collapsing, but there is decreased urine output history is also there. So we started on input output charting and put the patient on maintenance fluids. They already given 1.5 liters from outside itself, but on arrival there is only less than 90 ml in the
what is passive leg raising test?
Passive leg raising test will help will give an idea about whether fluid resuscitation will help to increase the stroke volume and cardiac output.
So why don't you do this patient the same thing?
Already initial boluses were given.
You are given here. Outside, we don't know outside what happened. You got a patient who is having hypotension, tachycardia, your ultrasound shows IVC collapsibility, and if your passive leg raising testing shows increase in the vascularity in the abdomen and there is no failure features, cardiac failure features, you can definitely give fluid. No more fluid can be given to this patient.
And on disability, coming to disability, Jesus is 15/15 with pupil bilateral equivalent reactive. And in exposure wise, the RBS is on arrival here, it is 140 milligram per dl. And there is ecchymotic patches all over the face and body and minor petechiae and purpura over the forearms.
How do you classify purpuras?
Petechiae, purpura and all differentiated with on the size of the
purpura is the smallest one.
2 to 8.
So there is no point in again telling the size. Purpura, petechiae, all these things. Fresh bleeds, red color, not ecchymosis. How do you classify them? Palpable. So you have to tell here whether it is a palpable purpura or non-palpable purpura.
It is a non-palpable purpura.
Non-palpable. Maybe due to platelet disorder.
Platelet disorder.
What is the importance of palpable purpuras?
It can be seen in other conditions like HSP hemorrhage.
HSP is only in the lower legs.
Lower limb.
Palpable purpura means what? It is vasculitic purpura. Vasculitic purpuras are very important in this type of cases. Okay.
And coming to adjuncts, the CBC-CRP point of care shows WBC of 15,000 with HB of 17.3 and hematocrit of 67 and platelet count.
What does it indicate?
It's a dehydrated.
It's a severely dehydrated patient. And all the features of dehydration is there here. So there is no point in restricting fluid in this patient.
And platelet count of 10,000.
What is liberal strategy and conservative strategy in ARDS management? It is basically explained in ARDS management. What is that?
Restrictive therapy means limited fluid is given.
Liberal strategy?
Without.
What is that? This patient, should we give liberal strategy or restrictive?
Liberal strategy.
So here we have to give liberal strategy. We know that there is cardiac failure, global hypokinesia is there. Sometimes all these things may be due to fluid deficiency. So you have to go ahead and give fluids and see what will happen to the patient. Instead you are restricting the fluid means again patient may deteriorate.
And when we took VBG, we shows pH of 6.9 with PCO2 of 54 and bicarb of 11, lactate is of 14 and creatinine is of 3.9, sodium is 136 and potassium 3.6 and bilirubin is 6.9.
The role of bicarbonate in this patient, will you give or not give?
Already carbon dioxide is 54, so we can't give that much.
That you can correct, no? With oxygen supplementation you can correct. Where bicarbonate is indicated, can you tell me?
In case of severe acidosis and
severe acidosis.
And also in case of post hyperkalemic cardiac arrest, we can give.
Okay, that is bolus. Here in acidosis, myocardial depression, this patient is having global hypokalemia, severe acidosis. So here shock. Here you can give bicarbonate. But normally it is not a drug of choice in acidosis, but when there is a cardiac failure, it is definitely going to help, especially when you are starting noradrenaline, adrenaline, all these things.
And ECG shows sinus tachycardia, and since the platelet count is 10,000 and there is ecchymotic patches and minor petechiae and purpura, we arranged for platelets and platelet transfusion was done.
What is a PTINR?
PTINR in this patient is 35.8 to 2.62. INR is 2.6.
APTT?
APTT is 74.6. Double increased.
Fibrinogen?
Fibrinogen is 84.
Low
side.
What is the ideal treatment for this patient?
We also
Simple platelet or something else? What else? Ecchymotic patches are there. PTINR is elevated, APTT is elevated, fibrinogen is low, platelets are low. What is your diagnosis?
Now it is changed into DI, means disseminated intravascular
DIC. So how do you treat this patient?
We also have to supplement with cryoprecipitate and
FFP and cryoprecipitate and platelet. These three things should be given. Okay.
So after the lab values, we diagnose it as DIC and we arrange for cryoprecipitate and FFP.
How do you, what is the dose of cryoprecipitate? What is the dose of FFP?
FFP 15 ml per kg and cryoprecipitate we can give 1 to 2 per 10 kg.
Okay.
And the rest of the investigation.
So what is your target fibrinogen in DIC?
More than 100.
100. More than?
More than 100.
What is the target? More than 150? Okay. 100 will become only normal. Actual normal value is 150. Less than 100 we should be very careful. Here it is less than 100 and your target should be more than 150, especially in this type of cases.
And rest of the lab investigation shows dengue virus IgG is positive and also HbSAg is reactive and D-dimer is more than 20 and LDH is 992 and ferritin values is 2443. And
how do you know that this HbSAg is active or dormant? The HBV DNA values taken.
HBV DNA will be positive in case of
active replication.
And USG abdomen shows raised echogenicities of bilateral kidneys. And in this patient, because of the we took blood cultures and started on IV antibiotics.
What antibiotic will select?
Antibiotics like
Higher antibiotic, highest antibiotic. You tell me one antibiotic with dose in this patient.
We started on piperacillin tazobactam combination.
Dose, first dose?
4.5.
First dose? 4.5.
4.5.
Subsequent doses?
Subsequent doses, because of this creatinine issues and all, we will have to reduce to 2.25.
Okay. What is the creatinine clearance? Is it important or
Yes,
not?
creatinine clearance is
Very, very important. One is it will tell you whether the patient is improving or not. Second thing, all these drugs should be given according to creatinine clearance. Okay.
And because of the persistent tachypnea and PCO2 buildup, we started patient initially on the NIV support also, and progressively cardiac enzymes and NT.
What are the contraindications for NIV? What will happen to BP in NIV?
It will reduce.
So here already patient is having hypertension, shock. Is it advisable?
If it is required, we can start this, because we patient is already on inotropic support and the BP is maintained.
Maintained. You told the patient is in hypertension,
Yes,
lactate is very high.
Then second
Initially.
initially it is 14, and after the initial fluid and the inotropic support, the second VBG shows lactate of around 5.5. It reduced from 14.1
Should we
to 5.
intubate this patient or no?
Then we intubated the patient. Initially we tried on NIV, and
Should we try first intubation or NIV first? What you will do? In this type of patients with hypertension, shock, sepsis, it is always better to intubate the patient, because trying BiPAP, patient is not improving, take some more time, have more damage. Better to intubate. Anyway, you will have to intubate this patient 100%. So better to intubate first itself.
And
Is there any contraindication for intubation?
So initially hypertension is there.
So after starting BiPAP, what will happen?
Initially we can start with normal inotropic support. The BP is made, then we can.
Then better to go ahead with intubation instead of trying all these measures, which is not going to help. We know that it is not going to help the patient. Okay.
due to the worsening of tachypnea and increased respiratory effort, we intubated the patient, and Ryle's tube insertion was done. We showed dark colored artery aspirate. So it also leads into internal bleeding. GI bleeding was also there. And for that, gastromedicine consultation was also done, and we arranged for the PRBC, since RT aspirate shows 500 ml of aspirate of dark colored. So PRBC transfusion also done in view of bleeding manifestations.
What is the HP in this patient?
Initial HB is around 16.
After
dilution? Then it dropped into 13.
13. So why did you give blood transfusion? What is the indication of blood transfusion?
Acute loss and more than indications. PRBC transfusion, we have to maintain the HB more than 7 if there is no.
Here it is 13, no?
But because of the acute blood loss and more than 500 hypertension.
Acute drop in HB is due to what? You are
Maybe due to
16 and with the 65 hematocrit. So you had given fluid, it has dropped. So why should we start hemoglobin transfusion in this patient? What is the indication of hemoglobin PRBC transfusion in sepsis? What is the cutoffs?
HB 7.
Less than 7. If there is a coronary artery disease, you should keep it
maintain
above
above
10.
10.
13 is not an indication for transfusion. Transfused.
1 pint. And nephrology consultation is also done due to worsening of the acidosis, and also anuria is persisting, and they initiated on SLED dialysis.
Yep.
And blood culture also shows gram positive cultures. and
Gram positive culture.
gram-positive cultures. So we treated the
Procalcitonin?
patient. Procalcitonin is 88.
88.
And the final.
So in a young patient, it's a young patient, no?
50-year-old.
50-year-old. 50-year-old.
15.
Gram positive culture in blood. What all focuses you will search for? Leptospira, you are suspecting. Let's okay, leave that. Leptospira will not come here. Gram positive cocci in the blood culture. What all things you will suspect? What are the focuses? Immediate focuses, where all you look for? You are blindly
Skin
treating the
infection.
patient. That is a problem. Gram positive cocci you get in the culture report. That may, so it is definitely after 48 hours only you are going to get it. So what, where all you look for the focuses?
Upper respiratory.
So in a, you have to see whether pneumonia is there or not. Second. What else?
Skin infections.
Skin infection. Look for any lower limb cellulitis. All these things. Then cardiac murmurs. Look for cardiac murmurs. Infective endocarditis. Then nowadays where else you look? Huh? IV drug abuses. This is one of the common presentation of gram positive cocci. Okay. So you have to always search for IV drug abuse. This patient, I am not telling this patient is having, but you have to look for that.
Okay. And now we reached in a diagnosis. We also send leptospira PCR, but it came to be negative. And IgM was done in outside, which was also negative. But HPCG alone is positive.
Okay.
And so maybe this patient has a, in X-ray it has right lower zone consolidation picture is there. So right lower lobe, pneumonia, LRT, sepsis, septic shock, multi-organ dysfunction with the DIC. And since HbACG is positive, we also thought about a differential diagnosis of cryoglobulinemia also.
Okay.
So basically cryoglobulinemia, it is the presence of cryoglobulins in the blood, that is type 2 or type 3 cryoglobulins circulating in the serum, that will be manifest as systemic vasculitis. So there will be palpable purpura with arthralgia and weakness and peripheral neuropathy, and pulmonary and kidney involvement will be there. And the most common triggering basic causes are chronic HCV or chronic HBV infections and underlying autoimmune diseases, HIV or hematological disorders. And there will be the basic pathophysiology is the deposition of the antigen antibody complexes in the capillaries and also the small arterioles and arteries. So we already discussed the clinical manifestations will be palpable purpura, weakness, arthralgia, arthritis, peripheral neuropathy, and we can also see hypercomplementemia, that is C4 levels will be
this
reduced.
patient complement is done?
It was not done. And if there is, it is occurring in the setting of viral infection, HCV, HBV and HIV and connective tissue disorder, we have to suspect this cryoglobulinemia. And there will be the lab investigations, either we can send cryocrit or cryoglobulin concentration. And the cryocrit will be more than 0.5% to 1%, cryoglobulin concentration may be more than 5 milligram per day. And it usually follows a chronic course, but it can also present as a rapidly progressive, even life-threatening condition. And the severity can be differentiated into mild and moderate. In case of mild disease, we treat the treatment will be general measures like pain control and wound care, and also prophylaxis against opportunistic infections. But in case of moderate disease, we have to give the immunosuppression therapy, and plus antiviral with the high dose systemic
What is the ferritin level in
corticosteroids.
this patient?
Ferritin level is 2000. And along with the systemic steroids, we can also give rituximab. If it is unavailable, we can give cyclophosphamide also. And for the patients with life-threatening disease like cryoglobulinemia associated with hyperviscosity syndrome, severe refractory skin ulcers due to cutaneous vasculitis, or high cryocrit level more than or equal to 10%, we can also do plasmapheresis in addition to the immunotherapy. And we can also send TEC before selecting the cryoprecipitate FFP or platelet transfusion. That will help us to differentiate between what have to be given for this. So in that case, in TEC we can think about the different values are there which help to do, that is the R value, K value, alpha angle and maximum amplitude and LY30. So R value will help us to understand the time which will take for the clot formation, and K value for the maximum clot formation, and also amplitude which helps us to understand the time taken to achieve the certain level of clot strength, and alpha angle is the speed at which the fibrin buildup will be there, and maximum amplitude is the maximum dynamic property of the fibrin and the platelet bonding.
Your tug is done?
Here, no, we will not send it.
Okay. Finally, what happened to the patient?
The patient is still in medical ICU and we are treating with antibiotics, and still inotropic support is there.
X-ray is normal?
Initial X-ray has right lobos on consolidation. Subsequent X-rays there is decrease in the patch, and also the inflammatory markers are improving, and already we given FFP and cryoprecipitate, so INR is also improved.
Okay.
Thanks.